sir, live.
Good evening, friends. Welcome to Indian Arthroscopy Society Basic Arthroscopy Learning course today. We are going to talk about hamstring ACL reconstruction. I think hamstring ACL reconstruction is in vogue these days, and people even who are doing the PTB have actually shifted to hamstring ACL reconstruction. We're going to talk about nitty-gritties of how to harvest a graft, what are the techniques, and how fixation would happen. We have eminent faculty here, led by Dr. Ravi Gupta, who is the Principal Director, Medical College, Chandigarh. We have Dr. Vikram Sharma, who is from Fortis Memorial Hospital in Jaipur, and Dr. Mohan Kumar from Bangalore. These are three eminent arthroscopy surgeons of the country who are going to lead this discussion. As we had already talked that these kind of basic arthroscopy series courses are informal courses where we would request people to ask questions in between. We have a lot of delegates also joining in on panel here, and they are free to open discussions and ask questions. Let us start our discussions. Let it be an informal discussion initially because Dr. Ravi Gupta will join over a period of time, another maybe 5-7 minutes.
Yes, I am already on.
Oh, you're already on, sir. So,
will you allow me to share the screen because he's saying
please.
that someone else is sharing, so I cannot share.
No, I think nobody else is sharing, sir. You can share. Sandeep, if you can help Dr. Ravi and to join, and he's joined already, but ask him to, and you can unmute yourself.
Yes, start sharing the screen, sir. Now you
Dr.
can
Ravi,
share.
can you share your screen, please?
Yeah, I'm trying to share.
Yeah.
So desktop one, ये क्या बोल रहे हो?
हाँ sir, click on desktop.
Okay.
So meantime, he connects IPS. I'd like to start your experience.
Yeah, sure. Please, Vikram. Yeah, you start.
So because as far as when we have started arthroscopy, we used to start that with the bone patella bone graft.
Yes.
And I know you were the teacher, and hamstring graft were looking a little difficult to harvest at that point of time.
Absolutely.
Because bone patella bone was appearing like a superficial graft.
Yes.
So what was your experience, how you shifted from bone patella bone to hamstring, and why?
You see, our Indian population are not into too much of contact sports, and we usually found a lot of ACL injuries in sedentary workers, in household females, in motorbike accidents, who are not very active athletic men. They were also not active into rehabilitation part. And BTB is something which requires a good amount of rehabilitation. And if somehow rehab is left not supervised properly, they end up having a bit of fixed flexion deformity. They lose a bit of movement. They usually used to be quite painful while sitting cross-legged and kneeling. And that is the time when hamstring graft had actually started. People had issues with the harvest of the hamstring graft, and they were quite afraid about fixation failures which might happen. But over a period of time, when we started arthroscopy, a transfix device started to come, and then transfix made our confidence into hamstring much more. Then the biopins started to come, called as rigid fixed devices. And with transfix and rigid fixed devices, we started doing hamstring reconstruction. And initial results were quite encouraging. Vis-a-vis rehabilitation was much faster. Patients did not end up with fixed flexion deformities. Patient had good range of movement. Even those who were not supervised quite a lot in rehab part gained quite a good amount of movement. And those failures which we used to see, vis-a-vis pain, loss of mobility, patient unsatisfaction, which we were seeing with BTB, eventually was not there too much with hamstring. And then subsequently, once these fixation devices became better, understanding of biology became better, understanding that partial ACL tears do happen, understanding the bundle concept of ACL, that you just need to maybe augment one part of bundle, started shifting over a period of time from BTB onto hamstring, because this is the graft which would allow us to do ACL augmentation, partial ACL repairs, stump preservation surgeries, So many advantages, plus the good fixation devices. So over a period of time, yes, we definitely have shifted. Though still we do have BTB in our armamentarium. We do use BTB in a select group of patients who are into very, very active combat sports. But most of the patients, as we see in our general population, because we don't see too much of rugby kind of injuries in our patients. So that is another reason for us not exactly to push BTB. And so we started doing a lot of hamstring now. And I think over the board, this is the experience of almost everybody here, that people have shifted from BTB to hamstring. Now, initial problem with hamstring used to be the harvest. People used to harvest by different methods. And that is why the reason are there that we wanted to discuss tricks of doing a harvest today. Because if you are able to get a good hamstring graft, then you can 4-fold it, 6-fold it, 8-fold it, depending upon the diameter you want to achieve. That is the beauty of this graft, that you can actually fold it multiple number of times, augment the graft with an internal brace, something like a synthetic tape to augment the graft. So there are so much of permutations and combinations which we can do with hamstring graft, which was never existent in BTB.
Exactly.
You would remember Mohan and Vikram, you guys are doing it long time. BTB always had problem. There was patients with patellar chondromalacia who had pain. There were patients who had short patellar tendons. They had problem. Then adjustment of the bone plugs vis-a-vis on the femur side and on the tibial side. Sometimes it would be hanging proud. Sometimes it would be going in. The calculations were a bit more challenging. Beginners had problems. Fixation devices were just screws, one up, one down. So you have to be really parallel with the graft. So many technical problems also created technical errors. And that is why people who were doing BTB had issues. But the learning curve in hamstring is much more slower. So what I realize now, almost everybody who starts ACL reconstruction is actually starting with a hamstring graft rather than a BTB graft.
Yes.
And that is why it is important for us to listen to people like you, Mohan, and Dr. Ravi, tricks and tips about the ACL, hamstring ACL reconstruction. Mohan, what is your experience? Did you also started with hamstring, or you started with BTB and then shifted to hamstring?
No, so when I started my fellowship training for an arthroscopy, it was straight away with hamstring only, sir. So started off with hamstring only, and then in between learned the other BTB and the quadriceps tendon and all those things.
So which is the year when you started, Mohan?
I started my training first in 2007, sir.
So that is what, because I think Vikram, if I remember correctly, we had met somewhere in
This was
2000 roughly, isn't it? 98 or 2000.
So this was about 2000, say 2 or 3.
2002 or 2003. You're right. Yeah, 2002 or 2003. So I think that is the time when we had actually started shifting from BTB to hamstring. 2002, 2003, and 2007. You rightly said, when you introduced yourself to ACL reconstruction, it was all hamstring.
All hamstrings.
And then subsequently, because when you start doing hamstring, you get revision cases and you get cases where you would might to do a PTB, and that is why probably you started with hamstring.
Yes, sir. Yes,
sir. Dr. Ravi, are we connected?
I am connected. I am listening to you, but I am not able to do what I want to do.
Unable to share this.
We can roll on the discussion with Dr. Ravi.
Yeah,
so actually, once again, if I talk to Dr. Birari,
Sandeep,
so
if you can
share the screen.
Share the screen, sir. Now start sharing.
I am trying to share.
Yeah.
I clicked on the button. Then I see, so many windows here. One is
First,
desktop.
select desktop, sir. Desktop window.
Share desktop. It shows the picture of Dr. IPS Oberoi, isn't it?
No. Now you have come. Now we are seeing it.
Click the PowerPoint below. Okay. Yeah, click it.
Click it. आगे sir, आगे.
Full
play पे चले जाओ और full screen कर दो.
Full screen, sir.
Full screen.
Perfect.
चलो हो गया.
बस बात बन गई सर. तो ऐसे करते हैं सर. Now things are all good. Slide discussion between myself, Mohan, and Vikram have initiated about BTB hamstring, how we guys shifted.
Yeah, I was listening to it.
Yeah, you were listening. So you can now carry on with this your topic. Another thing is, sir, that this is very, very informal. If you don't mind, we would stop you in between, ask some questions.
Yeah, I would love.
Wonderful, wonderful. Let us
So
start.
You don't mind if I am eating something, because, I was too busy during the day. I'm eating.
No worries. No worries.
So it's informal, as you told me.
Absolutely. It's an informal discussion, sir. Please.
So let's start with this. The topic you have given to me is with the STG graft, right?
Yes, sir.
ACL reconstruction, graft harvesting, the steps of the tunnel making, and then the fixation of the graft. So I will restrict myself exactly to these three topics, right?
Yes, sir. Yes, sir.
So this is the patient position. You can choose to have the foot on the operation table, and then the prepare with the betadine and then alcohol later on. And this is the way we prepare, and we drape the patient, pull up the limb. And this is if you are keeping it on the table, or I prefer this hanging down now. And then you should have all the instruments. Now this is regarding the portal placement and graft harvest. This is a slightly older picture when we were doing BPTB, transportal. But now I am doing both the grafts. I am talking that when we were doing it transtibial, but now I am doing both the grafts transporter. So you can give either a vertical incision. As I mentioned, it is an old picture, but now I prefer to give an oblique, because it is well established that the injury to the branch of the subpatellar nerve, that is less, infrapatellar nerve. So this is the way you make it. And then you, after incising the sartorius fascia, you identify the two tendons by just feeling with the finger. You can do it. And the superior one is gracilis, and then the inferior one is semitendinosus. So either you can use a open harvester or a closed harvester. Closed is relatively easier to use. The risk of pre-amputation of the graft is less with the closed. But since I had been doing the preserved insertions now, so I prefer to use the open harvester. So another important step is, before you harvest, you must look for the accessory insertions of these tendons. They are more common in semitendinosus. If you don't cut those, then there is a risk of premature amputation of the graft. So this is how, I'm looking for the, accessory insertion here, and then I cut it, and then I use the open harvester, and then the graft is taken. So this is the way I remove the muscle, because I am preserving the insertion. I will show you both. So this is the closed tendon you can take. First, you have removed the insertion. You have cut the insertion from the tibia. Then you have put some ethibond. Then you can use a closed tendon harvester. So this is what I meant about the early amputation. If you do not remove the accessory insertions, and sometimes these accessory insertions are actually too big, so you should, remove them. So if you are using it,
Sir, I have one question. So what is exactly landmark for this? Because when I started harvesting the graft in my early days, so I used to go sometimes very down or sometimes very high. So you just feel with your thumb.
You feel the tibial tuberosity.
So what is the landmark for incision?
I feel the tibial tuberosity, and then 2 centimeters medial and 2 centimeter inferior is the actual insertion. So that should be the middle point of your incision. So you gave approximately 1 inch incision. So that means 1 to 1.5 inch. So half of the incision above that point and half of the incision below that point. And in very thin patients, even you can feel the tendons through the skin, but that's not always available. So normally tibial tubercle 2 centimeters medially and 2 centimeters distally is the insertion.
So do you lift the pes? Because I have seen, Dr. Ravi, some of the surgeons who actually give an inverted hockey shape incision, and they would actually lift off the entire pes fascia so as to extract the tendons from outside. So do you do that way, or you
I never do that.
You never do that way.
I gave an incision slightly superior to the and in line with the gracilis. And then through that incision with a artery forceps or with a, right angled bent instrument, what do you call it? Leahy.
Leahy is a mixture.
So you lift that tendon that is actually lying underneath the sartorius fascia. It's sticking underneath the sartorius fascia. So you have to lift it from there. So, and I always close the fascia afterwards.
So we saw that you are actually taking both the tendons. There are surgeons who just would take a semitendinosus. So how do you decide that in this patient I would do both the tendons, or you always would do both the tendons?
As I mentioned, I am now for the last almost 7 to 10 years, I am doing preserved insertions only. So preserved insertions are not actually possible with one tendon.
Yeah.
So where I do not swear the insertions from the tibia. So I will show you in one of, pictures.
Okay.
The coming slides, how I do it. It's also available on the net. Actually, there is a video in the arthroscopy techniques. So one can see it that how.
So Vikram and Mohan, let us bring it. So sir is always doing a quadruple, which is a double loop of semitendinosus and a double loop of gracilis. Sometime Mohan and Vikram, do you do six-tailed as well?
All my ACLs are six-tailed, sir.
All your ACLs are six-tailed.
Six-tailed.
And Vikram, about you, sometimes would you do a six-tailed? Maybe you do a quadruple semity and another loop of a gracilis so that the diameter is around 8, 8.5, 9.
Yes, sir. Generally, this is a 5-strand graft.
This is
a 5-strand graft. So triple of semity.
Okay, you do a triple of semity, and so now we have 3, sir. Ravi, you said 4 strands. Mohan is 6 strand usually, and Vikram is usually 5 strands. So, how you are happy with a 4 strand, sir? And why, Mohan, would you do a 6 strand?
I initially started off with 4 strands, sir. But usually what happens, you have got adequate length, but the diameter is not always sufficient. It is 7.5. So I was not very happy with that. Once I started the tripling of both the grafts, I get easily around 8.59.
And the length is not a problem.
Length is not an issue at all.
Okay. We have Dr. Samanta, Secretary of Indian Arthroscopy, also joining, and Bhupesh. Bhupesh, you can unmute as well, because this is an interesting discussion going on. Dr. Ravi Gupta has an innovative technique of preserving the insertion of the hamstring, and he would then show this technique now. But we all would actually detach the hamstring. So we were just asking Dr. Ravi, what is the advantage of having the hamstring insertion? And because some of our surgeons like Mohan uses 6 strand and Vikram does 5 strand. With a hamstring preservation, we can't do 6 strand or a 5 strand. We have to do a quadruple. So how he is able to tackle with a thinner graft with the 4 strand sometimes? So Dr. Ravi, sir.
Yeah, I'll share some evidences from the science.
Okay.
As all of us, when we started, we were always comparing the strength of a normal ACL with the BPTB graft and the 4-stranded SEMI-T.
Yeah.
Out of the 3, the 4-stranded SEMI-T had the maximum strength.
Yes.
So in terms of Newton forces, right?
Yes.
So that had the maximum strength. So strength is not a problem with the 4-stranded. That's one. The second is I myself has done, lot of research on my patients, which is mostly published. This is also published in Arthroscopy journal now, this preserved insertion with 4-string graft, I think 2 years back. This is a randomized control trial, comparison of a free and a preserved insertion. Then, I have done comparison of free with the preserved insertion and BPTB. That is also published in the Journal of Knee and Trauma, and that is published from Germany. So actually, I feel more important is the accuracy of your tunnels and the biology. Now we are doing recently a study on, the ligamentization by looking at the MRI pictures with both the techniques. So I think And we have done another study where we have seen that if the graft diameter is less than 7 mm, that is also published internationally, then the rupture rate was significantly higher as compared to if it is more than 7 mm or 7 mm.
Okay.
So in more than 90% of the patients, we are able to get 7 mm with 4 strands.
Okay. Yeah.
So
you are satisfied with 7, or you would actually be satisfied with 8? What is your take, sir?
I don't mind 7, 8, 9. Actually, every patient, you know, there are a lot of anthropological studies on this. Recently, one study was published where people have tried to see the diameter of the quadrupole in comparison to the level of sports of the person. Whether he's an international sports, his was probably thicker, or a national or a state, but there was no difference. We ourselves have published 2 studies in the Journal of Orthopedics from Hong Kong on the anthropological measurements. So they are actually dependent upon the quadrupole diameter on the height of the person, the length of the thigh. So if a person is short, then his ACL is also going to be thin. And you know, it may be short ACL and thin ACL. So his quadrupole is also going to be of lesser diameter. So I feel it's more important thing is your biology, and you go at least equal to the strength of the native ACL.
So how would you say by arthroscopy that do you calculate footprint diameter, or how do you do it? That in this I am happy with 7, in this I would actually augment till 8, this I might go by 9. Is it by the height of the patient in the sports?
No. What I do is I preoperatively know the diameter of each patient now.
Okay.
If the patient diameter is less than 7 and he is a sports person, then I try to do BPTV. If it is less than 7 and a sedentary person or a recreational sports, even I do 6.5 also quadrupole, which is rare, very, very rare. So mostly it is more than 7.
Yeah, Mohan, you want
preoperatively you mean by MRI?
No. I have a equation. You can go to the, you write Ravi Gupta and the anthropological measurement of the ACL quadrupole graph. You will find this article. It's free available. Journal of Orthopedics, Hong Kong. So we have developed a formula.
Sir,
very accurate.
Yeah,
sir,
I
have seen your formula, sir. It's very nice. And thank you for that nice article. But my doubt is, a 7 mm, how can we standardize 7 mm, sir? A big knee is different. A small knee is different. Even as per your study, you have mentioned that. So what we understand is, at least we have to try and recreate 2/3 of the native ACL in the footprint. That is what is usually taught to all of us. So where does the 7 mm stand in terms of the footprint being very different from each person to person?
See, whatever we are practicing is based on the research, right? There is no absolute study in the literature which mentions that you should always fill the footprint, right?
Agreed.
And there are number of studies where people have said that the minimum diameter should be in a Caucasian population less than 8. In our population, what I found was 7, and it is a highly powered study. I can share that paper with you people. It is internationally published. So ultimately, we only come to know when we see our evidence. So we cannot say otherwise. So we should reproduce the evidence. Maybe I will request all of you to, start collecting your patients with 5 standard or 6 standard, and then you see the re-rupture rates. I have designed my studies quite scientifically, where we have tried to remove the confounding factors, in the international sports persons, national sports persons, what is the age group, so that the similar groups are there, age group, similar sports are there, right? And then you try to see what is the re-rupture rate. So I feel that if you people are doing 6 standard or 5 standard, and then maybe you also do a group with 4 standard, and then you compare the re-rupture rate in the 3. I don't know whether it is the ultimate, thickness of the graft which prevents the re-rupture, or it is the biology and exact placement of the tunnels.
I think that's a point well taken. I think Mohan and Vikram, I think probably we guys are a bit more apprehensive about graft failures, and that is why we are maybe a bit more because we don't want to waste the graft as well. So we have the graft material. We think that 4 is better than 5, and 5 is better than 6. 6 is better than 5. So maybe that's one of the reasons.
I don't know whether you people find this problem or not. So one of the important factors for rupture of the graft is when the graft is impinging on the wall or the roof.
Absolutely.
So
I
find even
thicker the graft.
I find that even 4 standard graft sometimes is impinging on the lateral wall, then I have to do some kind of notchplasty after the procedure.
Agreed.
So
I think 4 is the minimum.
Factors.
Perfect. I think that's a point very well taken, and I think if you have shown scientific data which supports it, I think that is more reassuring than our anecdotal evidence, which we think personally.
I think I have published around 20 papers.
That's a huge amount of experience. That's a huge amount of experience.
Ravi sir, one more question. In any of case, do you consider augmenting the graft with some fiber tape or something like? If
never. I have never done it.
Okay, thank you.
And one of the other thing I want to share with all of you is 90% of my patients, they are elite sports persons. Are you able to see my photo also, or you are just seeing the screen?
No, we are seeing your photo as well.
So this is the document record of multi-sport elite players. Incidentally,
so you can just maybe put your camera a bit, like this.
Yeah. Can you see it?
Yeah, we can see. Record of
this one. There is total number of 1,723 elite players who were operated in the last 5 years. This is the graph of different games.
Okay.
Right? And being in the North India hub where Punjab, Haryana, Rajasthan, Uttarakhand, so we got a lot of sports persons. These are the different games: athletics, badminton, baseball, basketball, boxing, cricket, dance, football, gymnastics, handball, hockey, judo, kabaddi, karate, kickboxing. So all sports are there. So when we do our studies, we try to, if you compare the rupture rate of a kabaddi player with a cricket player, you are going to get confounding because the amount of energy of the force is much more in kabaddi as compared to in a cricket or in a tennis. So we try to design our studies where we try to keep the other factors constant.
Quite reassuring, sir. Okay, let's maybe.
Ravi, this is Dr. Samanta calling you.
Yeah. Samanta, how are you?
Badhiya. Sab theek hai na? No. Suppose you are operating in a kabaddi people, and most of the people and our gurus and whatever we find the literature, people tell if you are operating on a kabaddi, it's better to go with the bone tendon bone. What's your take on that?
I started with BPTB in them, right? But you learn sometimes because the necessity is the mother of invention. Sometimes you get revision patients where the BPTB was done somewhere and it is already ruptured and he's an international player. And you did the revision with the STG and now he's doing so well. So, we all are in practice now for the last 15 to 20 years or even more. So then I started designing my studies like that. So I have a comparative randomized control trial on STG versus STG free graft versus STG with preserved and BPTB in elite players. Like in this data where I was talking, kabaddi is the maximum number, 739 patients out of 1,723 patients, 739 are of kabaddi. And our re-rupture rate is, not higher than the any of the international centers.
So even in elite athlete, if the graft after quadrupling is side 7, you are happy with it. You are not worried.
Yeah.
Perfect. I think that solves our question.
If it is less than 7, but if it is less than 7, actually IP ये बड़े लंबे चौड़े बंदे होते हैं ये कबड्डी वाले.
We usually get good graft.
उनका 7 आता ही नहीं है, उनका 9 ही आता है.
That is true. But sometimes there are female who are thin, but
female तो actually Unfortunately, हमारी studies की एक weakness ये है कि number of females in my study, they are so less. So I'm not really able to standardize the diameter in females.
Yes.
No, Ravi, the question is that every time we go to the different meetings and everywhere, people stress upon that your graph should be minimum like 8. It is all every time.
8.
Minimum
ask
is
them, ask them to show the evidence. Ask them to show the evidence.
No. It is like there are. It is lot many papers are also been there that people are because of the native ACL diameter is like this, so you have to replicate like 8 millimeter is a minimum graph that you have to be satisfied with when you do the 4-strand semity or say 4 semity and gracilis. So this is a really a nice evidence that you have got that even the safe 7 millimeter is going to succeed in even in the elite athlete. So this is a very good one.
I have my desktop here. Actually, ये बड़ी मुश्किल से ये अभी हमारी स्क्रीन शेयर हुई है, तो मैं इसको चेंज नहीं करना.
I will ask IPS is also doing in good numbers. IPS, your minimum take on ACL diameter is what?
No, it was 8, and as I said, Samanta, you rightly said, we have always been led by in all the meetings nationally, internationally. Everybody would say 8. I mean, I have, like Mohan said, I have also done a lot of 6 strands and 5 strands and 4 strands, and my cutoff was always 8. And this is the first time I am listening to Ravi, and it is so reassuring today that even in high-end athletes, elite athletes, he says that if the graft is 7, he's happy with quadruple. He's never done a 5-tailed and never done a 6-tailed, and 1,000 number of elite athletes. Results, I think, is a very big number.
They are only of the last 5 years. 1,723.
If re-rupture had to happen in these athletes, it would have happened by now. I think we have to, rather than anecdotal evidence, we have to listen to evidence.
Thing is that if Ravi is telling in 1,000% with 7 millimeter, your soft.
All those 1,000 are not 7 millimeter.
All are not 7.
No. Because of the study, you could apprehend, you could notice at the end that 7 millimeter is even 7 millimeter is going to be succeeding. Then this is a great message for all of us. Somebody's phone is ringing. If this is a great message for all the juniors, even to me at least, because sometimes I am not happy with the 4-strand semity. I take around the gracilis.
Absolutely, I think it's an
eye-opener. I will reiterate a point. I will say that, people have been successful with the Kennedy devices also. The 100% failure rate was not there with Kennedy devices, isn't it? It was more. So that means there was some fibrosis developing over that. Some fibers were being laid down over that. It's not so simple, 7 millimeter or 8 millimeter. There are so many other factors. I have done another study. I'm opening my computer, where we have found that the re-rupture rate in the contralateral knee is higher, around 15 to 16%, as compared to rupture of the graft in an already operated knee. So it's not only the graft, there's something in his body also which is making him more prone for ACL. So it's not that simple that we take that the 6 millimeter or 7 millimeter. I will say it's a very, very complex situation. But definitely you should try to have everything on your side. If you can give him a better graft, it's very good. But that's not the only thing.
Okay, that's okay. So that's not the only thing. I think level has to be the minimum, and a point well taken, I think. Yeah, Samanta.
Sir, all these graphs are sir, can I ask? Sir, all these graphs are graphs.
Go ahead.
All these graphs are graphs which are attached to the tibia, or these are free graphs, sir? The 7 mm graphs.
No, every graft is attached. I have never done a free graft for the last so many years.
It's always a attached, preserved insertion.
It's always.
I think that
maybe that also adds to some value.
So do you think, Ravi, that
I think that is the main thing. That's why I am again and again saying biology. That's the biology.
Maybe once you have an insertion which is there, it is much better graft for sure than a graft which is a free graft.
I have done another study where we have proved that the proprioception of the knee is much better with preserved insertion as compared to free graft. So proprioception also prevents the re-rupture.
Yes.
Right.
Ravi, there is a question on one aspect is that when you do this, getting your soft tissue graft attached to the tibia, do you do something extra on any specific? Have you learned that you have to be on the femoral tunneling? Any trick for us?
Femoral tunneling, I always take the point between the lateral condylar ridge, the meeting point of the lateral condylar ridge and the bifurcate ridge. And I tend to be slightly more towards the posterior side of the femur, even on that ridge, right? I don't go exactly at the junction of the T. So I try
So
to be
let's
more
maybe
towards the
proceed
vertical
with the
limb.
presentation, and then probably in one of
Yeah,
those
yeah.
videos you can explain.
Yeah. Okay. Welcome, Rajiv. Rajiv is joining. Yeah, Rajiv has
Till
joined.
this point, I think there are a couple of take-home messages which you have given us. Number one is graft size probably is one of the not the only factor. Probably insertion, preserving the insertions are helping even in the patients with repreception, with graft incorporation, return to sports, and less re-rupture rate.
Just
So
going
this
a
is quite
little,
encouraging.
off the track, because it's an informal lecture. I opened my, list of publications. So why I am, you are all so great surgeons. Unfortunately, in India, we do not keep our data well, right? So
Yes.
if you people all do this research, you will find, and internationally, I feel proud in sharing. 6 months back, I was visiting professor in Mayo. And when I reached their sports injury clinic, the chief over there, he said, I know you. I had been reviewing your papers. So that is how we get, internationally known if you start doing it. So you people, all of you have so much data. I think you should design your studies. I will read some of my studies, which I did in, we have an advantage of PG students. So I give thesis. I supervise them so closely so that, we design the studies, we execute the studies well. So this is one: preoperative joint inflammation has no bearing on the outcome of arthroscopic ACL, where we have seen IL-6 levels preoperatively, right? And ACL with bone patellar bone graft is associated with higher and earlier return to sports as compared to hamstring tendon graft. This is in knee surgery sports traumatology arthroscopy 2020. Comparing the role of different treatment modalities, that's not in the ACL. And then we have anterior cruciate ligament tear due to non-contact mode of injury associated with higher incidence of meniscal and chondral damage. No difference in outcome of ACL with BPTB versus semi-T gracilis with preserved insertion. This is a randomized controlled trial. Role of arthroscopy surgery in degenerative knee. There is a lot of hue and cry that someone did a arthroscopy in degenerative knee and he can do a damage. I remember 4 or 5 years back, there was a headline in newspapers in Delhi. We were doing that conference of Dr. Deepak Chaudhary that, people are doing arthroscopic debridement and they are doing more harm. I think you must be remembering, all of you. Then I came back and gave a thesis. It is a very good method. It is also published now. So I will request all of you to start publishing your work.
Ravi, can we go ahead with some of your videos?
Yeah, I will go. So this is how we do it. I think all of you are expert. I don't need to tell you how you measure your graft diameter and then how you prepare your graft. And the way you fix it, you can prepare it. There are different ways of, I don't do tensioning anymore these days. I used to do it around 15 years back. This is an old tensioner. Now I do the manual tensioning. And this is the force which we were keeping at that time, 15 pounds. So another important thing is, in 1 or 2 cases, I think at least 2 cases, I dropped my graft in between the trolley and the patient. And, you feel so embarrassed. So this can be a complication, because IPS told me that when you tell your lecture, also talk about your complications.
But these used to happen when you used to use free graft. Now it doesn't happen because your insertion
if I
is
use BPTV, this you can see BPTV here sticking to my glove. So BPTV has to be free. So I have developed this protocol that always handle it in the basin. Don't give it in the hand of the staff nurse. So now, first you do the meniscus pathology. This is in a very old video when we were doing outside in. So I think IPS, everyone is expert in this group. So I can skip some of the things.
Yeah, for sure.
No, it will be archived in the arthroscopy podium. So everybody is probably you have to even go ahead with some of the basics.
Okay.
It is not only for the groups.
Okay. So this is how we do it. Outside in technique, this is a PDS, very cheap, 100, 200 rupees, loop on one side and then the single thread on the other side. And then you pass your artery forceps and hold the thread. And then you pull the loop outside and then you will tie it. It's very simple. Even now I do it sometimes because it's very cheap. Then notchplasty I rarely do, but sometimes nowadays I do it at the end of my procedure. Earlier, when we started, I was doing it before my procedure. Every notch, which was, inverted V, that was being converted into inverted U, but now I don't do it. So that is also kind of a preserving the biology. But sometimes you see this residence ridge, which does not let you see the actual lateral condylar and bifurcate ridge. So you may get a false impression if you don't curate it out. So I use the curate to, remove if it is too prominent a ridge. So curate is very safe rather than burr or a shaver. But sometimes you have to use the shaver or burr if it is too prominent, especially in females, it can be a problem. We all know that there is no actual isometric point, but to the best possible, a point each on femur and tibia, which best describes the anatomical attachment of the ACL, is the isometric point. So this is how I define on the tibial side. This is the posterior border of the anterior horn of the lateral meniscus, and I take the tip of my hammer on this posterior border. You can see this video, and then take it just in front of the PCL and place it there. So that is my isometric point for the tibia. And then I drill my guide wire. And once the tip of my guide wire comes out, then I want to be doubly sure that it's not impinging. Otherwise, if it impinges, the anteriorly placed tibial tunnel can be a catastrophe, like you can see in this patient, which was revised by us. If it is slightly interior, you can tackle it by putting an anterior screw. But if it is too anterior, then you should revise it on the table itself. So this is how I do it. I do the extension, and then I see where the tip is going. If it is going inside the notch, then I am very happy that it will not be impinging on the roof.
Dr. Ravi, a question here is, you always use a tip hammer or sometimes you use an elbow hammer or a footprint hammer?
I have only used elbow hammer in live surgeries because I was not provided tip hammer. So I love tip hammer.
Okay. Vikram and Mohan, any thoughts about footprint hammer? And
yeah, I generally use a tip hammer because
Mohan,
that is
I am more comfortable with the footprint hammer, sir. Arthrex wala footprint hammer.
So Samanta, about you?
No, I always use the elbow hammer.
Everybody has a personal choice, probably an elbow hammer or a tip hammer or a footprint.
It's like driving a car. If you start driving an automatic car, you love that. If you start driving a gear car, you love that. So ultimately, you should be able to reach the destination.
Ultimately, it is very simple that your guide wire should be at the heart of your old ACL stump, and it should not be impinging on the medial, on the lateral side and the apex. So that is
perfect.
Whatever suits you, we can do that.
But do you change your zig preferability if you still have a graft material there, ACL material there? Suppose it's a partial ACL tear. So would you actually change your zig for that, because you then need to preserve that amount of tissue there? Any take on that?
No, I don't change it. I don't change it because of the partiality, because I just incise in the partial stump.
Oh, you incise in the partial stump. Okay.
Suppose this is the stump. I just incise it so that my K-wire comes in between. So the old ACL is just on both the sides of my graft.
No, agreed. For a tip hammer, yes, you can do it. But Mohan, I am asking because you are using a footprint hammer. but you do already have some partial ACL there. So how do you place your footprint aimer, because footprint is not fully exposed on the tibia?
In single bundle reconstructions, the footprint aimer will be difficult because there's already a stump there.
Yes,
In
yes.
those scenario, you will have to use the tip aimer.
Yeah, so that is the carry on point, that if you have a ACL which is chronic, you don't have a stump, you are not doing a stump preservation kind of thing, you may as well go ahead and do a footprint aimer. But almost all the cases, tip aimer or an elbow aimer is good if you have a stump there. And
Yeah, yeah.
So here I want to, just give in a comment.
Yeah.
I never touch even a single fiber of the remnant ACL. So in a partial, if it is, half or 1/3 or 1/10 left, I don't touch it. I want to, act as a kind of a sport and biology to it. And it is well established that it also gives some, the nerve supply and blood supply to the your graft. So people sometimes ask me that, because in live surgeries I have done it, this sometimes ask, now you have stuffed lot of material into the notch because you have not removed that. I have never faced that problem.
Okay.
Sir, excuse me, sir. Just one question. I also believe in remnant preservation, like you said, whatever is already there attached between tibia and femur, unnecessarily we should not remove. For that matter, even the tibial stump. Now, the advantage with the elbow aimer is we can go behind the stump and then preserve the stump. And you will still have a good hold on the tibia and your jig will not wobble when you are drilling. That is the advantage of the elbow. But when you are using the tip in an already present stump, the wobbling factor is always an issue for me. Any tips to overcome that, sir? Or in these scenarios, are elbow aimers better because you go behind the stump and put it on raw bone where your jig is going to be sturdy?
Yes,
I think as you do more and more cases, sometimes we get patients where the ACL is kind of avulsed from the femoral side. Nowadays, people talk about repairing that ACL also, but I don't do. I do ACL reconstruction in that. I try to take my graft almost through the middle of that ACL. So that kind of acts like an envelope around the graft. So I think with the experience, you can avoid those things about wobbling of the aimer or not. I have never found that problem.
I think carry on point for beginners is that if you have no tissue which is there on the footprint, you can actually, as Mohan said, you can use a footprint aimer or any kind of aimer. Footprint gives you much more stability once you're putting your zig. As Samanta said, if you have a stump and you want to incise the stump and go in, you can actually go ahead and do either an elbow or a tip aimer. And Bhupesh also had a rise point that sometime when you put your tip aimer and you are beginner, you may not be able to hold the zig very well because it's sitting on a mushy soft tissue there. You might want to overshoot it and go over a good bone, and then probably elbow aimer is good enough. So depending upon your capabilities and the pathology which we see on the stump, you can decide which type of aimer you can use. But Ravi has an ideal point that more you start doing ACL reconstruction, you will realize any one of these zigs can work well. It depends upon how you train your hand on that. Perfect. Yes, sir.
So, IPS, I think all of us started with so poor instruments. When I started my ACL surgery, the supplier in Chandigarh, there was no supplier. They were coming from Delhi. So they did not want to come to Chandigarh for 1 or 2 cases in a month. So they were giving me a jig which was so bad. If you start learning, you're driving on a truck, then Maruti looks much easier to you, isn't it? That is how we have all started.
Yeah. Okay.
So now I am, just showing this one of another complication when you are doing this wire, because we use mostly the same wire so many times. So we should be careful that it's not gets jammed inside the reamer. So my scrubners always try to pass the wire through the cannulation of the reamer before we use that wire. Otherwise, you can get this problem like this. It's going. If you are not aware, it will go into the femur. So that can, just be careful. Now what I do is I catch hold of this here because we need to use it again and again. So I catch this tip with a artery forceps so that a little bit of jamming it will help. You see, it started rotating now. Yeah, it's actually a little bit jammed. Yeah. So,
sir, I would like to ask the only issue is that Dr. Rajiv Raman from Calcutta, sir, Ravi sir.
Yeah, Rajiv.
Hello.
Ask, please.
Sir, the only issue is that when you hold this tip of this bead pin with an artery, some amount of metal debris is always it gets floated inside the knee, which causes synovitis. So earlier I was using that. What happened when that part rotates? You get some metal debris inside the joint. It's very difficult to take it out. All the small, very tiny metal debris.
Take it out. Not difficult. It's impossible. Because sometimes when I use my shaver for notchplasty, even then the debris of the metal, it goes into the soft tissues and AC a little bit. I can see those particles, but somehow synovitis was never a problem in my patients.
I think for the juniors, it is better to use the just tip of a blunt curate on the top of your
curate. Yes.
Usually I do that like that, because it will never produce these metal particles, and don't try to remove those metal particles. This is a hard job, and these metal particles never do harm to the synovium.
Yeah. Another small tip is, especially when you're doing serial reaming, if you have a 9.5 graft or a 9 graft and you want to do a 7 and then go to 9, after reaming your 7, you can park the guide wire in a safe zone in the femur and slightly mallet it in the notch. And then ream it through. That is another safe way to do it.
Yeah, that's a good tip.
So on the femoral side, earlier we used to talk about the 10 o'clock, 9:30 o'clock position. Now we have a landmark there. So I will show you both. So this is the earlier clock picture. You are all aware of it. When I was doing it, even then the results were not really bad, but we should improve if the new evidence is coming. So we have improved. So this is how we were doing it with the offset guide at that time. This is a transtibial kind of which we have been doing. And the femoral guide wire, we used to put like this. In the femoral also, now, with the lateral condylar and the bifurcate ridge, the risk of anterior femoral tunnel is very, very less. With the earlier offset guides, depending upon the size of the graft, sometimes you are using 8 mm, and then, you tend to be a little more anterior. Then you could fix it by, inserting the screw anterior to the graft. That would push the graft a little posteriorly. But if it is too anterior, then you have no choice. This is one of the cases which was revised by me. It was operated somewhere, and then the patient was not getting benefit of the surgery. So when we did the MRI, the graft was kind of a lax, and this was too anterior. And this is arthroscopy picture. That is the point where it should be, and it is actually lying here. So that was what I was telling. I never remove these grafts. I used another tunnel posterior to it and lateral to it. And this is the new graft. So it did not, cause any problem. Now it is almost 10 years. This is a very 10 years old picture. Patient is doing well. He's from Govindgarh. So this is the O clock. You tend to be around 9:30. Another important problem is posterior blowout, especially if you are thinking about fixing it with the screw. You must have an adequate posterior wall. Otherwise, this weak posterior wall, your screw can go into the popliteal fossa. So if you get this problem, then you should change your fixation from interference screw to endo button, or you can use the screw from outside in, from the femoral side outside in. But you should always be able to avoid it. How you do it? For the beginners, use the proper sized offset guide. And this is another technique. Before fully drilling the femoral tunnel, you make an impression with the reamer. Take the reamer out and see that you have adequate posterior wall. And then you can again take the reamer in, and then you can do it. So first you make the impression of the reamer.
Ravi, how much offset you are using? 9 mm?
I don't use offset anymore. I use the landmark of going between the lateral condylar. I'll show you when I will show you my, the transportal. I'll show you what I do. I have never used any offset guide for the last almost, I think 8 to 10 years.
Vikram, are you using question to Vikram? Vikram, are you using a offset or just your eye estimation, your anatomical landmark?
So just eye estimation and do a hole with a microfracture. So
you do the microfracture all, you see the old ACL stump where it was there, follow the Sharpe fibers and you do it, no?
Yeah, generally say whatever we say 7 millimeter front from the posterior wall. So I just do not follow the like the old ACL because sometimes the footprint is not very much visible.
Okay.
So
Mohan, what's your take?
Yes, sir. It's more of freehand technique, sir. Freehand using the anatomical landmarks. That are no use of jigs, femoral jigs.
And the other still I have changed my portal before making a final tunnel. So I recheck it with the medial portal. So where I am, where my microfracture hole is. So that is again, I think, important tip.
Okay. So, okay, Ravi, your take on that.
So this is the video, what you want, you are asking a question to me or should I continue?
No, you continue.
So this is, video you just saw that the passage of the graft should be very, very smooth. Your graft should not be too tight when you are pulling it. Otherwise you are lacerating the graft, and sometimes what happens is you have made your tunnel very well. The graft was okay, but when you do it, it becomes tight because you had soaked it in the saline. So never put it into the, the bowl of saline. What I do is I wet my gauze piece and then I squeeze it thoroughly and then I wrap the graft. So that does not make your graft swell.
Any antibiotic you use, sir?
Never, ever. So this is the problem with the transtibial. There was another question that whether you are using offset guide or not. As I mentioned, necessity is the mother of invention. When we started, my offset guide, it broke around 10 years back. And then, I did not have any option rather than to use those landmarks. So which has proved to be a boon later on. So with the transtibial, this is the problem. Your graft tends to be vertical. And as we all know that these are the latest studies later on which have shown that that is the not ideal place. This is the ideal place. And this is what I do. This is a lateral condylar ridge here. This is a bifurcate ridge here. So I tend to be somewhere here, not here, somewhere here. So that is by eyeballing that I don't blow out my posterior wall also, but I don't want to leave more than 1 to 1.5 mm posterior wall. Actually, as we all know, the ACL is not depending on this insertion. ACL is somewhere just on the edge, which is, giving it a real, the place of isometry, what do you say? So this is the total footprint, but I tend to be somewhere here. So that is how I do it. This is the awl. I use the awl from the medial portal and then I keep my awl. So this is the lateral condylar ridge. I am slightly towards more posterior side. And then I put my guide wire in hyperflexion position. And this is the reamer. This is the cannulated drill bit. And this is the cannulated drill bit. And then I measures because I am using the preserved insertion, then mathematics is very important for me. If my mathematics is not good, then my graft is either going to be too loose or my endo button is not going to flip. So I have to be very, very accurate. So in this case, as you see that it is 42 millimeters tunnel. And if I use 15 mm loop, right, then this is 42 minus 15 is 27 and plus 10 mm I want for the flipping of it, then I will drill 37 mm of my femoral tunnel. 27, sorry, ream up to 27. Then pass the suture through the beath pin and park it in the femur. Actually, in this lecture, I showed the tibial side first, but now for last almost 10 years, I am doing femoral side first. Because if you do tibial side tunnel first, then the saline keeps on coming out from the tibial side when you are drilling the femoral side. So that does not allow the knee to inflate. So I always do the femoral side first. So now from the tibial side, I am pulling the suture and then I will pull the graft in. So this is the paper which, you know, in 2016, this is the technique. Even video is available on the net. This is arthroscopy techniques. It is the journal by the arthroscopy journal itself. In this journal, they only put the techniques. So if someone is interested in looking at the actual video, so that is available here. This is how I do the tensioning of the graft. When I was doing a free graft even, so I pull maximally at the tibial end and then around 10 times full flexion, full extension. So that removes all the kinks and it gives tension to the graft. So I don't use a tensioner anymore. And then you spread the 4 strands and in the middle, I tend to put the this screw. Another point, I think all of you must be doing it. This nitinol wire, I don't just put the nitinol wire in the center. I first use this cannulated drill bit because that places my nitinol wire exactly in the center. It does not go into the substance of the tendon. So, and then I am using this screw. These 4 strands are being pulled, and I think that's it. Yeah.
Dr. Ravi, do you sometime on the femoral side use an outside in zig, or is it always from inside that you're going to read?
I've never used it. Outside in, you know, it came for basically all inside when it started. For children, sometimes people use it, but for children, what I do is for immature skeleton, I make a posteromedial portal on the femoral side, and I make the micro fracture with the awl as I am doing here. But I am putting my beath pin from the posteromedial portal, which goes inferior to the epiphysis.
So Mohan and Vikram, I mean, we saw here sir is actually spreading the 4 tendons and then putting a screw in between. Do you do the same, or you would actually pull the graft on one side and put a screw on the other side?
All the strands to one side and screw on one side, sir.
And what about you, Vikram?
Yeah, practically I also do that because we don't have any device with we can spread the graft.
So how, sir, Dr. Ravi, you have 4 strands, so you need actually 4 hands to pull them away.
we have in a medical college, so many students are there. We have 8 PGs with us.
So we used to use this kind of thing where we used to spread the graft, and then there was an intrafix. I mean, if you remember, there was a plastic sheet we used to put and then put a screw. Mytech had it. So was that because of that you started putting the screw in between?
No. If you IPS, you know, I think both of us, we started almost at the same time, started doing transfix, if you remember.
Yeah.
So if you look at the original technique of the transfix by the Arthrex, they were using this spreading without a intrafix. So I learned it from there.
So do you find that putting a HA coated screw, which is slightly bit more harder screw, and then spreading all the graft, the graceless is a thinner graft, it might cut the graft?
HA screw I have stopped because of 2 reasons. One is, you already mentioned that sometimes it cuts the graft. The other is, this is a very brittle screw. I don't know whether you have faced it or not. The screw breaks sometimes.
Screw breaks.
So this is, you know, the Smith and Nephew screw, which is also, you know, material very similar to the HA. I don't know what material, I don't remember. This is a very good screw.
Yeah, we do have now biocomposites which are there, and I think biocomposites are good screws.
Yeah, I think this is a biocomposite.
Yeah, biocomposites are good screws.
Ravi sir, in case of bone patella bone, do you use the same composite or bio screws, or which kind of screws, or the metallic one?
In PPTB, I have always used metallic screw now. earlier I used these, these bioabsorbable screws. I don't remember how many years back, but I am not happy with them. I always use metal screws in BPTP, and I'm very happy.
Metal of
We
same
did a
size?
thesis, I think 3 years back now, 100 cases of BPTB, 100 cases of preserved insertion, randomized control trial. So the results are excellent with metallic screws, and they are much cheaper also.
Ravi, I'm going to ask you a very basic question from the juniors, because there is a question to me that when you go give the screw for your side, suppose for your metallic screw for your bone tendon bone for the right knee or the left knee, do you find something your trick on the right knee or left knee? Because sometimes you put the screw on the left knee, it is bit difficult.
Yeah, again, I would say Dr. Basin always teaches us a, video in basic arthroscopy technique, where he starts with showing, brushing your teeth with the left hand. Actually, the problem is, if you are a right hand dominant or left hand surgeon, but the arthroscopy surgeon should try to develop ambidextrous. So, now I don't find any problem. Might be,
I think Swarnendu, Dr. Swarnendu Samanta has asked, try to ask, there is rotation of graft when you put it on the right side, because it's a reverse thread. So you try to rotate the graft and go, screw tries to go posteriorly. Whether that happens in your scenario.
But it's a BPTB graft, na? And the metallic screws, they go so smoothly, they don't, rotate the graft. So in the bioabsorbable screws, you have to sometimes struggle, or you have to sometimes kind of tap before you use the bioabsorbable screws.
Yes, that's why I'm asking, because it is better to use the tap. So that if you just make a notch on that entry, or if you just notch or tap, then it is easy.
If you use metallic screws, then you don't find this problem. They act like a tap itself.
Yeah.
So any take on Vikram? I believe you use more of a variable loop devices, like Sir showed endo button, which is a fixed loop device. You probably use, as I remember in your practice, probably variable loop devices as well, and I think Mohan as well. I think Dr. Ravi, do you use a variable loop like a tightrope, or you don't use it?
IPS, I think we have discussed it earlier, because I started my surgery with Cure Surgical, right? So he was the only person who was able to send his man for 1 or 2 patients in a month. So I did lot of, they had this, what they call the fixed loop device, retro, or what was the saying?
Retro, there was a retro button. Yeah, there was a retro button.
So I used lot of retro buttons. They were good. But then I did lot of those variable loop devices from Artrex. But I found a problem in some of cases while I was pulling.
Yeah.
The thread broke. So I was not sure about my sports persons that when they start doing their rehab, what will be happening to their threads inside. I shared this, my experience with the, their founder of Artrex also in one of the international meetings in Canada. So he said that your assistant might have used a lot of force in pulling, otherwise it should not break. But I was not happy, so I stopped.
Okay, you stopped using it. So Vikram and Mohan, your experience about variable loops?
I don't use loops at all, sir. I am more of a screw, both femur and tibia.
Femur and tibia. Okay.
Vikram is using lot of your adjustable loop. Vikram is a master of ACL surgery, so I will try to understand his technique of using the variable loop, because I am too scared about using the variable loops, because sometimes variable loop, if it overshoots, there is a problem. So your message, Vikram, for the juniors?
Just the breed of using maximum graft. So because I can triple the graft and sometimes the quadruple. So with the adjustable loop, I'm quite flexible with that. So that is one of the reasons I've gone for flexible loop. Otherwise, I'm very much comfortable with the fixed loop also. So I don't use screws on the femoral side. I'm of a suspension device mostly on the femoral side. And previously I used to use that fixed loop, but when I experienced that sometimes my graft is wasted. So that's why I shifted to a flexible loop.
I think femoral is probably everybody's own preference. Somebody would put a screw, but on the tibial side, everybody is probably, most of us are using screws. are anybody of you using a backup fixation device as well after a screw? So maybe Dr. Ravi, we can start with you.
No backup for the tibia.
Samanta, no backup, just a screw. Okay, Ravi, sometimes backup.
When I was doing free graft, I have used it in so many patients, the staple along with the screw.
Just because reassurance?
No, I'm not using anything on the tibial side.
No, not. Okay, so it was probably a reassurance. And
yeah, it's a preserved.
Mukesh, about you, Sandeep, Raman, Rajiv, anybody of you using a backup device now?
No, not routinely, but when I'm not sure that the tightening, there is no quicking sound, then usually I put a post.
And the screw diameter is usually +1 or +2 on the table?
+1 if it is a normal bone, but sometimes what happens if you think I put my just trocar inside, if it goes very easily, it's +2. If it goes tight, there's +1. If it's not going, I think same size. So that is the rough guide we use in our clinical practice. In my clinical practice.
And even in revisions, you don't use any backup fixations?
Yeah, definitely. All revisions, I use this backup fixation. All revisions cases. And if you see IPS Japanese data, they are doing it in primary fixation also, because they said with cyclic loading there is some loosening. So primary ACL also they are using a suture post everywhere. In all the Japanese studies you see, they are using the suture post there.
So probably Dr. Ravi, you are an eminent researcher. Have you done any kind of research on this backup without a backup fixation, or you want to do such kind of research as well?
In PCL, because recently I started doing PCL for preserved insertions again. But you know, when you are doing ACL and PCL, then you have to have a free graft on one side. You can only have one preserved. So in those cases, when I'm not happy with my screw fixation, I use another special kind of cheaper fixation. What I do is I make a drill hole. First I put a bead pin through the edge of the tunnel, posterior to the tibial tubercle, to the other side of the tibial surface, towards the lateral side. And then with the cannulated drill bit, I enlarge it, and then the threads of the graft, I take it through this tunnel and take it over the tibial tubercle and I tie it there.
Okay, so that's again a backup. It's a bony bridge backup.
So that saves the other devices also, and that's what I do.
That's a very clever technique of a backup fixation without using any extra implant. Wonderful. Tirath, any question? Mukesh, any question? Amol, any questions?
Yes, I have a question.
Vikram has a question. Okay.
Tirth had definitely different. Anything to ask, Tirth?
No, Vikram and then Tirth. Yeah.
Mukesh today is not telling anything.
Ravi sir, in starting of your talk, you have said that there are 10 to 15% chances of contralateral knee injury.
Yeah.
So in that case, do you focus on a strengthening contralateral limb also as a return to sports criteria?
Rehab, in the rehab part.
Yeah, we have done a thesis on core strengthening actually. Yeah. The core strengthening, in some of patients, we divided our patients after the surgery into two groups. In one group, we gave core muscle strengthening exercises in addition to the normal ACL rehab. And in the other group, we only gave the standard ACL rehab. What we found was if you are giving core strengthening, the re-rupture graft rate as well as the contralateral rupture was slightly less. But the power of the study was not too high. So I think more people need to do this research.
So sir, don't you think that contralateral limb should be strengthened enough with these findings?
Vikram, actually, it's not the strength of the limb. There are so many factors. Yeah. There is one factor which is known as the neuromuscular coordination. And then there are factors like what is the flexibility of your body. Hyperflex people, they rupture it more. And then
collagen failure as well. Collagen, the type of collagen.
What is the slope of the tibia, and what is the width of and the shape of the notch? What is the diameter of your native ACL? We have done a study and we are going to publish it on all those factors. What are these factors which make it more rupture on the contralateral side?
Absolutely.
Amal, do you want to ask anything from Ravi? Ravi is the real researcher in this group, because you can ask anything on your ACL to Ravi.
Perfect. I think probably no more questions here.
Last.
Yeah, Vikram, last, and that probably will conclude then.
Yeah. So Ravi sir, in cases of posterior blowout or lateral blowout, you said you would like to prefer outside in screw.
Yeah.
So suture disc can be option in cases of lateral blowout.
Suture disc backup rather than a screw if there is a blowout.
Suture disc on the outer side of the femur, isn't it?
Yeah.
Yeah, it's good, but I have never done it.
Yeah, there are surgeons who have done it.
Dr. Baskin is very fond of
it lateral side, and they put a suture disc as well. I think that's
an
acceptable method to do it.
Yeah, Ravi was referring to, if there is a posterior blowout, he was telling that you can go even with the screw, but it should be from the outside to in.
Yeah.
I think it was interesting, very, very interesting discussion today. And Ravi, you actually gave a lot of insight, which is actually backed by scientific evidence. And that is very, very important.
I'm so happy to see you all after a long time.
Absolutely. And we had a very informal discussion with Vikram and Mohan asking questions in between, and Bhupesh and Rajiv joining in also in discussions. Samanta was always there, as always in all of our basic webinars. Quite interesting, some of the insights regarding graft diameter, use of the zig, the types of zigs which we can use, different patterns, and then backup fixation to use or not to use, and then the graft hamstring preservation, I think insertion preservation. So a couple of new insights which we have got, and I think a lot of people who are doing ACL or have started using ACLs would be much more happy now after hearing your talk. And we must thank you for all the research work, because Indians invariably don't have a lot of publications which are coming out.
And can I request to all of you that please start preserving your data, and please start publishing it. But India is we have a lot of variety and lot of numbers, so we can lead the world.
I think Samanta, you, me, and Ravi would talk sometime in privately, so how we can actually initiate more research work in Indian Arthroscopy Society among members, and we'll probably fix up a meeting between you, myself, and Samanta, and then we'll.
And another thing I would like to share, so that the other people get encouraged. I have got 3 projects funded from ICMR for ACL.
That is quite
great.
When you start doing it, you get a lot of money also. I got my KT 1000 from ICMR.
That is great. I think a lot of new initiatives have been taken by the Executive Committee of Indian Arthroscopy Society, including webinars, basic teaching courses, IAS General. And I think scientific publication is something which probably will request you to chip in and take some lead. Samantha?
Yes, nowadays with the guidance of, because IPS is currently the president, because he is the impetus of our force, and with his IPS guidance and with the people that like Sandeep, Rajiv, and all the Vikram, and all these, Bhupesh is too good. Bhupesh is too good. Even the people like they are really giving too much impetus to the arthroscopy all around years webinars. Ravi, will be astonished to see if you hit the our website now. It has completely been changed what was two years before. So be involved with all this.
IPS, IPS is a very dynamic man.
For sure, Ravi, we will take guidance from you.
I will request Ravi to take care of our academic this thing, and I will be talking to the IPS and all the EC, so that you be involved in this academic. How is it go with the academic things and keeping the data? So thank you, Ravi, for joining in.
Sent me message for this lecture. IPS, can you repeat what I wrote back?
Yeah, I'll just repeat on the chat box. Yeah.
So it is always nice to see like people like Vikram, because he is a very, very close friend of mine.
Almost everybody is actually.
Yeah, Ravi, you'll be nice to know that is a very, very close group.
I can repeat. Close group. IPS is not able to find. I wrote back, I am always at your service.
I'm unable to find that, but I think
Samanta also, and I am always at the service of the society.
I can tell you anything, because you are too close to me. But because
thank you very much.
IPS is the boss now. Okay.
Wonderful. And I think very valuable insights from Vikram who and Mohan both participated in discussions and made the discussions lively. Friends, we have a webinar on orthobiologics. I think orthobiologics is something we have not talked too much in sports medicine. Professor Elizabeth Kohn. She is one of the leading a person who is actually into research in orthobiologics and sports medicine, and she's vice president of the ICRS. I mean, ICRS is the International Cartilage Research Society, and we are lucky to have Professor Elizabeth Kohn with us on 31st of July, Friday, which is at 6 p.m. We should not miss this discussion with Professor Elizabeth and get her perspective about what are latest happening in orthobiologics. We would also tie up with, try to talk with her and tie up Indian Arthroscopy Society activities with ICRS so that we come to an international platform with help of these leading international faculties. So please join in on 31st July, 6 p.m. on Friday for this interactive orthobiologics webinar. And
Sure.
thank you entire